Hello all, good morning. Today we will be discussing regarding the management of paracetamol overdose. So this will be the synopsis in which I will be dealing the topic. First of all, we will go ahead. What are the clinical features? What you have to do when the patient is coming to the ER? What are the basic investigations that you need to send in? And what is the specific antidote management that you need to follow here? And follow-up and special concerns. So this will be the synopsis of the presentation. Coming to the drug paracetamol, it is one of the most common overdose that we see in the ED. So every day when you look at the statistics, when you look at the number of overdoses coming to the ED, one of the most common overdose that present to the ER is paracetamol, maybe because of its easy availability. So that is the first thing. The next thing, what is the normal therapeutic dose? When you have to see that 15 milligram per kilogram body weight in divided doses is the therapeutic dose, or you can remember 4000 mg every 24 hours as the therapeutic dose. So if the therapeutic dose exceeds, it will lead on to the overdose. So that is the therapeutic dose for the paracetamol. And as I said, the therapeutic dose per kg body weight 10 to 50 milligram per kilogram hourly every 4 to 6 hours, or maximum of 80 milligram per kg per hour in a day. So that is the dose that is to be used as the therapeutic level. Now, what is a major problem with paracetamol overdose? See, when the patient is going for an overdose, they will most likely, they may need a liver transplantation. So, the end point, the patient might go into a liver transplantation. So, that is a problem with paracetamol. So, if the patient is not treated properly, not currently timely antidote is not administered well, and supportive management is not done correctly, the patient can go in for a liver transplantation. So acute liver failure, fulminant liver failure requiring a liver transplantation. So that is the one of the worst thing that can happen with paracetamol overdose. Now coming to the toxicity. See, when you refer textbooks, there are multiple data that is available. What is the toxic dose? So I have compiled all those things and I have put here. So when you think that single injection, if it is more than 200 to 250 milligram per kilogram body weight, the patient is taking as a single injection more than 200 to 250 milligram per kilogram, that can be considered as a toxic overdose. The next thing, or if the patient is taking more than 12 gram over 24 hours. So the patient has not taken a single dose. Instead of that, the patient has taken multiple doses, but it is more than 12 gram in the last 24 hours. It's like a staggered overdosing. Or else, what you can remember is that more than 6 grams or more than 150 milligram per kilogram per hour for the last 24 hours for at least 2 consecutive days. So the patient has taken it over 2 days consecutively and more than 6 grams in a day or more than 150 milligram per day in 24-hour period, you can call it as toxic ingestion. Or the patient is straight away taken more than 350 milligram per kilogram, there is a high chance that the patient will straight away go into severe liver toxicity where OTPT is going more than 1000. So that is regarding your toxicity. So single injection more than 200 to 250 or more than 12 grams over 24 hours. That is a simple thing that you can remember. 12 grams over 24 hours. For a pediatric age group, if you want to remember, you can remember in this way of 200 to 250 milligram per kilogram body weight. If the patient is taking more than 350 milligram per kilogram in a single shot, that itself is a very high dose. That is almost the double the dose of what is the toxic dose, and straight away the patient can go for severe liver toxicity. Now coming to the most important thing of pharmacokinetics. Why you should be able to understand, why you should know about this. So one most important thing, it is rapidly and completely absorbed from the gastrointestinal tract. So paracetamol is completely absorbed from the GIT and serum concentration usually peaks approximately after 2 hours. So this information is very important. So when the patient is coming to the ED after consuming a paracetamol overdose, there is no point in sending a serum paracetamol level immediately. If the patient has consumed it more than 4 hours only, there is a point in sending the serum paracetamol level. As you see here itself, the serum concentration peaking time itself will take 2 hours after ingestion. So ideally, we should be sending a serum paracetamol level if we have the facility only after 4 hours. We will come into that discussion later on. And another most important thing that you need to remember is that food delays the absorption. Food, if the patient is consumed along with the food, so that will delay the absorption. Also drugs like opioids and anticholinergic. If the patient has anything consumed along with this group of drug can again delay the absorption. And peak concentration occurs 4 hours after ingestion. So that is the reason why we are sending a serum paracetamol level only after 4 hours after the ingestion, and elimination half-life is 2 to 4 hours. So that is the pharmacokinetic. Now coming to the toxicokinetic, as you all know, the toxic metabolite is the N-acetyl P-benzoquinolamine, NAPQI. That is the easiest thing that we can remember. This is a toxic metabolite that causes all the damage related to the paracetamol overdose. So in therapeutic doses, what happens? It is metabolized into two major non-toxic metabolites. Routinely, when the patient is just taking to a therapeutic dose, it is divided into sulfate and glucuronide conjugates. But what will happen? Only very small amount of NAPQI is formed with following a therapeutic dose. But when the patient is taking a overdose, what will happen? The more NAPQI is formed, and the patient, normally there is no chance of getting it neutralized. So highly reactive toxic metabolites, which is formed by the cytochrome P450, responsible for the hepatocellular injury. So the toxic metabolite is NAPQI, N-acetyl P-benzoquinolamine. Normally in therapeutic doses, only two major conjugates are formed, that is sulfate and glucuronide. Very small amount of NAPQI is formed. But what will happen in the overdose? In overdose, there is increased formation of NAPQI, which depletes the glutathione, and once glutathione is depleted by more than 2/3, it covalently binds to the critical cellular proteins, resulting in damage. So normally very small amount of NAPQI is formed and it will be neutralized, but in overdoses, the glutathione is unable to the neutralization is not going to happen. So as a result, there will be more damage to the cellular proteins. So in therapeutic dose, as I said, the glutathione make it non-toxic, but in overdoses, enough glutathione is not in our body, so that will result in more injury. So this is again whatever we have discussed, the chart what we are seeing, the acetaminophen getting divided, what will happen in the glucuronide and sulfate metabolites, which is non-toxic. But in normally very small amount of NAPQI is formed in a therapeutic consumption, but if it is overdose, NAPQI is formed, but there is no enough glutathione to neutralize this, resulting in cysteine and mercapturic acid, which is normally it is non-toxic, but in an overdose there is no glutathione for neutralizing this NAPQI. So as a result, NAPQI will result in damage. Now coming factors, which are the factors that will affect the toxicity? So the most important factor is excessive intake of paracetamol, delay between PCM injection and ACT therapy. If the patient has taken paracetamol and is coming to a facility where there is an ACT therapy and the therapy is getting delayed, that can affect the toxicity and the patient can go for fulminant failure. Excessive cytochrome P450 activity, the patient who is having excessive cytochrome P450 activity. Chronic alcoholic, the patient on already who is having AIDS, because there will be insufficient glutathione reserves in them, and the patient who consumes tobacco. So these are the factors that will affect the toxicity. Patient who is concurrently on anti-tuberculous therapy, phenobarbital, some herbal products. If the patient is already having some herbal products, these are all chance that the patient is already having a chance of liver toxicity, and also in malnutrition and Gilbert syndrome. So these are the factors which affect the toxicity of patient with paracetamol overdose. Now coming to the clinical features is very explained clearly in this chart. You will have 4 stages: stage 1, stage 2, stage 3 and stage 4. Stage 1 usually within the 24 hours after ingestion. Initially it will be just the GI symptoms: nausea, vomiting, abdominal pain, sweating and pallor. So that can be the patient, not pallor, the patient can be very pale because of vomiting and dehydration. LFT can be normal at this phase. So initially when the patient comes within 24 to 48 hours, the LFT can be normal. Stage 2 usually start within the 1 to 3 days after ingestion. The liver injury slowly starts developing and the patient will start developing upper right quadrant pain, and there will be transient lies in the LFT. Coming to the stage 3 to 5 days after the ingestion, hepatotoxicity peaks, rapid and severe encephalopathy, hypoglycemia, glucose, lactase, phosphate abnormality. The patient will go into coma, and probably, if not treated properly, they can even go to death. So that is usually in the stage 3. Stage 4 is basically the recovery stage who survives the stage 3. So this is the clinical features. So depending upon the days after ingestion, you can divide into stage 1, stage 2, stage 3 and stage 4. Stage 1 you will have just the upper GI symptoms like vomiting, abdominal pain, and LFT used to be normal. Stage 2, initially with 1 to 3 days it will start. Liver injury develops, upper right quadrant abdominal pain. Slowly the LFT start rising. Stage 3, there will be hepatotoxicity, rapid and liver failure, encephalopathy, hypoglycemia, the patient can go into coma and death. And stage 4, if the patient who recovers from stage 3, they will go into stage 4, usually after a week's time. Now coming to the evaluation and diagnosis. The patient has come to the ED after the consumption of paracetamol. As an ED physician, what all things you should do? First, you should have a high index of suspicion. Always you have a high index of suspicion. Whenever you are not getting a patient, you are not very clear that what is happening to him, you need to take history again and again. So always keep in mind for this presentation, somebody is coming with abdominal pain, vomiting, and you are not very sure why he developed. There is no past history. You feel some suspicion, you have a high index of suspicion. Always consider paracetamol because it's one of the easily available drug, and also consider a co-injection also. Whenever you see a toxicology case, always remember that you need to consider this co-injection also. And the most important investigation what you need to learn, serum paracetamol level is the basis for determining the diagnosis and treatment. So concentration should be measured in every patient. So ideally it should be done for every patient. As I told, the peak concentration will only happen after 4 hours after injection. So that is the reason why only after 4 hours you should be doing this. Or you can send immediately if time is not known, or the patient is coming to you after 24 hours. So ideally to be taken after 4 hours after injection, but if the patient is not coming to your facility within 4 hours or maybe after 24 hours, so whenever the patient is coming to you, you can take a sample and send it for serum paracetamol analysis. So serum paracetamol analysis is the key point in the initial investigation that you wanted. But in some centers, you don't have that facility. You don't have a facility to get a serum paracetamol level. You can't wait. It's taking 24 hours. It is taking 2 days. You have sent the sample to some other center, accredited toxicology lab. So don't wait. So if you have any doubt in mind, start N-acetylcysteine therapy. So the key message will be, if you have facility to get a serum paracetamol level, you are going to get a result within another 3 to 4 hours. No need to start NAC therapy. You can wait and see the serum paracetamol level and decide regarding the treatment. But if you don't have a facility, you are not going to get a result within the next 3 to 4 hours, or it is going to take a long time. Without any doubt, start N-acetylcysteine therapy. Patient presenting more than 24 hours, serum paracetamol level may not be elevated, but treat as per the clinical features. But the patient would have developed acute liver failure. So the patient will have abdominal pain, raised LFT. Then you can start again NAC therapy. So then always, as I said, you have to send for other tox screen. You have to look for any other co-injections. Blood gas, very important. You have to look for lactate level, glucose, because hypoglycemia, because there will be multiple reasons for hypoglycemia. One reason would be the patient is not taking any feed, multiple episode of vomiting, and liver failure start developing, the gluconeogenesis is impaired. So as a result, the patient will go in for hypoglycemia. Liver function test, most important investigation will be your enzymes, SGOT and SGPT, and INR. Again, very, very important investigation that you need to send. Then you have to know something regarding the Rumac-Matthew nomogram, which I will show you in the next slides. And you have to go in for the RFT, serum electrolytes and amylase. So these are the basic set of investigations that you need to do. The patient had come to your facility with a high index of suspicion of paracetamol overdose. So if the patient is coming to you immediately, what you have to do, you do not send a paracetamol level immediately. After 4 hours of injection only you need to send. And what are the other investigations that you need to send, I have said. Now, this is what is called as a Rumac-Matthew nomogram. So in one axis you see the acetaminophen plasma concentration, and the other axis hovers after post-injection. So suppose you are getting a lab value of 30. So they have said that 30 microgram per ml is the serum paracetamol level. You have sent a sample after 4 hours injection and it is coming to be 30. So you can just see in this axis where is 30. 30 is here and it is 4 hours after injection. So the 4 hour after injection is here. So 4 hour it is coming down the line. So this you see here, this is the Rumac-Matthew line. So if the level is above this line, you see this, if somewhere the level has come here, we need to start treatment with NAC therapy. If it is below the treatment line, so this is the treatment line. If it is below the treatment line, no need of N-acetylcysteine infusion. So this is the Rumac-Matthew nomogram. What you have to do, you have to get the serum paracetamol level, and you see 4 hours after injection you have taken the level and see what is the level. If it is somewhere like 300, so it will be here. So if it is 300, it is above the treatment line. You need to start the treatment with NAC therapy. But if it is below that, no need to start. You can wait and watch. So this is how you need to use a Rumac-Matthew nomogram. Now, coming to the next, management. So the patient has come to your facility. Again, if the patient is presenting you within 1 to 2 hours, you do a gastric lavage, and if it is less than 1 hour to 2 hour ingestion, you can do a gastric lavage, or otherwise you can think of giving activated charcoal 1 gram per kg in all patient who presents within 4 hours of ingestion. So gastric lavage you reserve for the patient who is presenting you to with 1 to 2 hours after ingestion. After 2 hour ingestion, if there is any chance that there is a delayed absorption, as I discussed previously, you can try gastric lavage, but routinely within 1 to 2 hours only, if the patient is presenting, there is a role for gastric lavage. Otherwise you can go ahead with activated charcoal. Stabilize the airway breathing circulation. Specific antidote is the N-acetylcysteine. So we have a specific antidote available for paracetamol, so we can use it. So what are the indications for NAC therapy? As I said clearly, a serum paracetamol level above the treatment line at 4 hours, or after that you need to start the NAC therapy. Or you have a suspected ingestion more than 150 milligram per kilogram in whom serum paracetamol will not be available in the next 8 hours of ingestion. Again, you can start the patient on N-acetylcysteine therapy. Patient with unknown time of ingestion, but the serum paracetamol level is detected. So again, you can think of giving N-acetylcysteine infusion. And patient with history of PCM overdose, already he is having an hepatic injury, we need to start the patient on an N-acetylcysteine. But if you don't have any chance of getting a serum paracetamol level, if you don't have facility, you are sure the patient has taken a toxic dose, without any hesitation, start them on an N-acetylcysteine infusion or oral tablet as per the patient comfort. Now coming to how will you start N-acetylcysteine infusion? That is again one of the most important questions. There are n number of protocols. There are many protocols. So what we commonly follow is the 20-hour IV protocol, where you are giving an initial loading dose, then you are continuing with a maintenance dose. So initial loading dose of 150 milligram per kilogram IV over the first 15 to 60 minutes, followed by 50 milligram per kilogram over 4 hours, and then 100 milligram per kilogram over the next 16 hours. So this is the standard 20-hour protocol that commonly practiced. So 150, 50, 100. So first initially over 1 hour, then 4 hours, then 16 hours. So it will be in total, it will be somewhere like a 21-hour protocol, what we call as 20-hour IV protocol. Or else you have a simplified protocol. What you can do is that you start with 50 milligram per kilogram hour for the first hours, then you continue at 6.25 milligram per kilogram per hour for the next 16 hours. So it's like initially you gave 200 milligram per kilogram over the 4 hours, then 100 milligram per kilogram over the 16 hours. So it's very easy to remember. We can practice this. But if the patient is not willing to take IV, you can even start with oral protocol. That is a 72-hour protocol, 40 milligram per kilogram, 140 milligram per kilogram per orally. 4 hour after loading dose, start 70 milligram per kilogram Q hourly for a total doses. If the patient vomits, you can repeat the dose. So that is regarding the oral protocol. Now coming, there is something called as a SNAP protocol. When you Google or if you go through any literature, there is something called as a SNAP protocol. This is again one of the simplified version only. So you have two things, loading dose and extended dose. One, you start with 100 milligram per kilogram body weight over 2 hours. Then you start 200 milligram per kilogram over 10 hours. And then you have 200 milligram per kilogram over 10 hours. So it's something called as a SNAP protocol. It is also agreed by the WHO so that we can follow this also. So whichever protocol you wanted, you are giving a loading dose and you are giving an extended infusion dose. So NAC therapy needed to be done, but you have to follow this protocol for paracetamol. Either any of this one, 21-hour, simplified 20-hour or SNAP protocol, or if the patient is not taking orally, if not willing for an IV, you have to take an oral injection. Any of this protocol you need to follow. Now the question comes, shall I repeat N-acetylcysteine? When should I repeat it? So you have completed the protocol. When you should repeat the repeat NAC therapy? So what you have to do? Check an ALT by the PCM level as the patient is approaching the end of infusion. Suppose it's a 20-hour protocol or a 21-hour protocol. At the level of 18 hours, you send one more investigation, ALT or paracetamol level. If you have available paracetamol level, that is best. But if you don't have, you can check at least ALT. If ALT or AST is elevated, what you have to do? You have to continue the infusion at a rate of 6.25 milligram per kilogram body weight. If you don't have a facility for a serum paracetamol, either the enzymes you can check and INR also you can check. INR is elevated more than 2, you continue the infusion. So question here is when to continue the infusion. So when to continue the infusion, either there is a paracetamol level is still detected, or you have an elevated INR or liver enzymes, you need to continue the infusion for 6.25 milligram per kilogram body weight and repeat it after 12 hours till the INR is decreasing below 2. Treatment can be stopped if the serum paracetamol level is undetectable or AAT, AST or ALT is decreasing and INR is less than 2. If possible, recheck the paracetamol level. Ideally, ALT bar AST can be and INR can be checked 12th hourly. It is recommended. If you have the facility, you can go about it. Now coming to the special circumstances, you have a patient with unknown timing of injection. Serum paracetamol level, what is the role? But as I said, if you have any hesitation, start on NAC therapy. Hepatic failure, early IV NAC, continue till the liver transplant. Manage the encephalopathy. So that will be the treatment protocol that you need to follow. Hepatic failure, early IV NAC. If the patient is already presented to you with hepatic failure, start NAC therapy immediately till the patient is going for a transplant. Massive injection, double the final infusion site. So we used to start with 6.25. If it is more than like 300 mg per ml, sorry for the typo, 300 mg per ml, the patient is consumed very high dose, 12.5 milligram per hour, you can continue. And pregnancy, again PCM crosses placenta, so NAC therapy can be started. So now this is the standard one, that is the King's College criteria for liver transplantation, which all patient you should refer for a facility where you have a liver transplantation. So we have two things. We have ALF related liver failure and non-ALF. So acetaminophen liver failure and non-acetaminophen related liver failure. So we will see the acetaminophen related liver failure here. If the pH is less than 7.3, straight away that is a candidate fitting for a liver transplant. Or an arterial serum plasma lactate level is more than 3 millimoles per liter, straight away you can take the patient for liver transplant. Or else there is a presence of grade 3 or 4 encephalopathy, INR more than 6.5, creatinine more than 3.4 milligram per deciliter. All these three are there, then this patient is a candidate for liver transplantation. So this is the King's College criteria for liver transplantation due to ALF due to acetaminophen toxicity. Now there are other recommended treatments which is not of much use. Cimetidine only in animal models, no role. Methionine, cysteamine, dimercaprol, no role. Extracorporeal, it is cleared by HT, but there is no definite indication for HT to be done unless and until you have a severe metabolic acidosis, renal failure associated with this, then only there is a role for hemodialysis. Otherwise, routinely there is no role for hemodialysis in paracetamol therapy. When you can think is that you don't have a NAC facility, but the patient has gone for an AKI or associated with severe metabolic acidosis. So we have discussed regarding the paracetamol overdose. So just to give an overview of what paracetamol overdose is. One, it is one of the most commonly overdoses that happen because of its freely availability. You have to remember the toxic metabolite NAPQI. In normal therapeutic doses, very small amount of NAPQI is formed, which is neutralized by glutathione, which is metabolized by glutathione. But in heavy doses, glutathione reserve is not enough to neutralize this NAPQI or to metabolize this NAPQI. So this NAPQI is the toxic metabolite creating the issues here. So depending upon the patient presentation, we have 4 stages of clinical presentation. Stage 1, 2, 3 and 4. Stage 1, usually the upper quadrant pain, a little bit of vomiting and all those things only will be there. Nausea, vomiting. Stage 2, will the patient start developing mild tenderness in the right hypochondrium. Stage 3, the patient will have severe encephalopathy and severe features of severe liver failure. And stage 4 is usually the recovery phase who recovers very well from stage 3. So that is the clinical features. What are the investigations that you need to send? Most important one investigation what we mentioned is the serum paracetamol level only after 4 hours after injection. Then you have to look for your liver function test, SGOT, SGPT, AST, ALT, PT-INR, electrolytes, look for acidosis, any evidence of acidosis. So that is the most important investigations that you need to remember. And the patient is presenting you to within 1 to 2 hours, you can think of gastric lavage. Otherwise, after 2 hours, there is no role for gastric lavage. There is no point in doing a gastric lavage. Stabilize the airway breathing circulation. Start NAC therapy. You can use Romac-Matthew nomogram. If you have any doubt, without any hesitation, start NAC therapy. There are multiple protocols. 20-hour protocol, 21-hour protocol, SNAP protocol, all these things are there. Idea is we are giving a loading dose and we are continuing the infusion for 20 to 21 hours. So when to stop NAC therapy? If the serum level, paracetamol level is undetectable or INR is decreased, you can think of stopping the paracetamol stopping the N-acetyl cysteine therapy. Otherwise, you need to continue it for another 12 hours and you need to repeat it and see how the patient is responding to your NAC therapy. And these are the major indications for NAC therapy. I hope it's clear. Thank you for your listening. Thank you.